So what I would like to do is kind of go through the therapeutic response. And so what we've learned about the virus since it has been there is what we do know about the virus now is a lot more than we did. It's actually probably the most researched thing that we've ever, disease that we've ever done. It's crowdsourced now. There's every country in the world studying at the same time. There's more money being poured into it than ever. And so the best way that I can think of how this looks, and I will borrow this from Peter McCullough, is that you've got basically the onset to this day 21, 30, okay? Day 14, being really bad. Day 7 being a big difference. I mean, everything seems okay until day 7, and then you're like, I can't breathe. And I think many of y'all, hopefully, not many, anyway. So it happens a lot. So, well, what I'd say is in the viral proliferation phase, you get the fever, sore throat, fatigue, body aches, nasal stuffing, loss of taste and smell, anorexia, nausea, diarrhea. And then on that, when you bring it over into that cytokine injury, what you're starting to talk about is cough, difficulty breathing. And then what we do know about the spike protein in general, it is increasingly and incredibly thrombogenic. It actually attaches to the platelet itself and actually causes microthrombosis, something we haven't ever seen in a lot of viral diseases. And so when it actually crosses into that microthrombosis becomes chest heaviness, pressure, dyspnea, which is shortness of breath, starts to desat, and then a lot of times people are showing up day 10 at the hospital, and my thing is, why aren't we doing anything before that? And I think to me that is, and so that's really what I've started to do, and following McCullough's lead. McCullough published this paper in February of 2021, and basically said not only is it not one therapy, it's lots of therapies, and which is common in our treating of any viral illnesses. We need a lot of therapies. But it's combining what we already know, repurposing some medicines. I mean, heck, remdesivir is repurposed as well. I mean, that's really what we have right now. And so, in all honesty, this is kind of a lot of what I've been applying under his tutelage to go ahead and get my patients better. And I think, for the most part, it's worked pretty good. In fact, even starting anticoagulants in the outpatient setting has been an interesting thing, but we've got some really great anticoagulants that are easy to start. They don't require much monitoring, and they work pretty dang well. We can thank We can thank the PE world for that in terms of pulmonary embolism. So again, and when you talk about hospitalization, mortality, benefit, again, it's a multifaceted, high-targeted, sequential, multi-drug treatment. That's really where we need to go. It's not, to me, the biggest issue that I've had is you're positive, go home, take Mucinex, go to the ER when you can't breathe. And I feel like we're doing our ERs a disservice by waiting to actually treat. And so a lot of what I'm doing is getting people on certain things early, obviously assessing them each individually and see what their risks are, the treatments that need to be done. And so in all honesty, So anyway, the first thing that we have that's really pretty awesome is, again, the monoclonal antibodies. And again, the monoclonal antibodies, again, each one's different, but obviously this one attaches to the receptor binding domain, which is, and the Regeneron's, I think, actually is an anti-spike molecule as well. But these things really allow you early, and the key is actually, even talking, hopefully, Mr. Mooney after this we can talk, but talking to David Faulkner and Dan Roberts, trying to get the ability to have these infusions early in the outpatient world. A lot of doctors' offices have said, we don't want people with COVID in our office. And that's really a big disservice, okay? And so what we've tried to start doing is getting people in early and getting these infusions, not in the ER, but in getting them in my clinic. And I'm putting them in a part of my clinic that I've got an RN there. The problem is sourcing it through the state. Anyway, I'm not going to say it, but the air source burden is making it a little bit difficult. But so we're working toward that goal. And my goal is, I don't want my patients to have to go to Silicaga to get it, and I don't want them to go to the ER to get it. I want them to get it in a safe outpatient place. And that's one of the things that I think in the next couple of weeks we need to get done. Because again, this early intervention is a huge way to not only decrease the stress on our healthcare system, and I think that's not being done effectively. So again, and that's the same. The Regeneron is another cocktail that works, and these things do well when they get in the system. The biggest problem is most of my patients, the second that they find out and we try to get them treatments, they say, well, it'll be an 8-day wait. It's not. It's useless on day 8. I mean, it may not be useless, it pretty much is useless, okay? And so to me, it's how do I get, I mean, I got 6 clinics. I got, probably 500,000 square feet of space. I just need the drug, okay? And that's what the state we're working on. Because in all honesty, I don't want to send them to the ER. The ER is already overloaded to begin with. So that's one of the things we're working on. But if you don't have the access to monoclonal antibodies, the next thing is looking at things that actually affect viral replication. And so this repurposed drug again, there's earlier it was hydroxychloroquine, now it's really ivermectin, is we're working on getting this stuff early to cause viral replication to decrease. If you have a lower viral replication, then the overall response from your body is going to be much less, which keeps you away from that cytokine storm, which keeps you away from showing up at the ER. So far, regardless of what CNN says that it's just for horses, it's a medicine that actually won the Nobel Prize for Medicine in 2015, and it's still one of the top 10 medicines in the world that have changed the world in general. It's been given to billions of people in third world countries, and it has been safe, it's been effective, it has cured river blindness. And I think in many ways, that to me, that we have 85% improvement in multiple trials as well, shows you that the question is why are we not using it? And I think at minimum it's probably maybe water is safer, but otherwise there's very little downside to trying some of these medicines. And I think us not trying them is anyway, not a great thing. So the next thing that we look at is really, and we know this already, and this is something that's used already in the outpatient setting. It is used especially at the hospital. It's been used for viral disease for a long time, which is corticosteroids. It doesn't matter your corticosteroid, dexamethasone was tried in the hospital, prednisone's great, has a longer half-life. Dex packs are great because they're easy to take. But getting somebody on corticosteroids early, which would be probably day 4 before the cytokine storm hits, really makes a difference in their overall mortality and then whether they're going to show up to the hospital. And again, we know this. We have tons of data on it, which is surprising that we're not doing it. So we can do it in a systemic way, and in all honesty, people have also done it in an inhaled and nebulized way. And again, we're talking about multiple drugs, hitting things early, getting things under control with very, almost minimal risk. I mean, each patient has to be assessed differently for what other medicines they're on, but why are we not doing this would be the biggest thing. So again, primary endpoint urgent versus hospitalizations by using inhaled budesonide versus usual care. In the STOIC trial, 87% primary endpoint reduction. Why are we not doing this? That's the biggest question. And I think getting physicians acclimated to using these therapies early and often will really save lives, but also decrease the overall stress on our medical system. Lastly, interestingly enough, colchicine's been around since antiquity. Actually, I think the Egyptians actually discovered it. Shows you how corrupt our pharma system is, but it actually was repatented with a trial in like 11 years ago and got put back on the market, and the colchicine price went from nothing back because somebody finally had the patent on it, and then they cut the patent in 3 or 4 years, so colchicine got expensive, but it's not patented anymore. But it just shows you how an interesting thing is that some of the medicines we use every day really haven't even been tried, because we just know. I mean, Tylenol, aspirin. So
what is that?
So colchicine, classically, I use for it's a tubulin inhibitor. It's an anti-inflammatory, and it's been used for gout for a long time. It's really easy to take. The side effects are nausea and really, maybe some diarrhea. In all honesty, you probably can have that anyway. And so again, this Col Corona trial was actually, again, the primary endpoint in terms of reduction was great. I mean, it showed that that basically colchicine versus placebo decreased hospitalization by 25% or death, and decreased death by 44%. To me, I mean, it's a disservice that we're not getting these things in early before they show up at the hospital. And then the last thing, and this is what I've started doing in the last couple months, is getting people on early anticoagulation. Again, the things that are killing people are systemic thrombosis. Systemic thrombosis is very different than your deep vein thrombosis. Deep vein thrombosis, you get a big, deep, clot, and that clot breaks off and then causes issues. Systemic thrombosis is your blood itself with a viral load is actually causing microclots, and those microclots are actually being spread and go into the lungs. You can, and when you look at it from even physiology of the heart, you see elevated right-sided pressures. You know, you're like, there has to be a clot there, and then you get a CT angio, and there's not a clot there. There is clots there. There's just tons of them, and they're teeny. And so again, that's why anticoagulation and full-strength anticoagulation is so important. And so, you know, again, when we look at intermediate dose anticoagulation, aspirin, and hospital mortality, you know, it significantly reduces death by almost 50%. That's a hazard ratio. So, again, not showing you anything that's not in the literature. And I think the question is why are we not doing it? Yeah. So,
why do you think we're not? I mean, just kind of what are your thoughts? I have some thoughts. I mean, I think that the sort of the mask and vaccine sort of obsession, or I think it's a little bit of a false security. And I think the early sort of, when physicians came out with some of this data, they were beat down so hard. And in a lot of
still are.
And punished.
Still are.
Yeah, it still are. And punished in lots of different ways. But kind of what are your thoughts as to...
So, I mean, I do know that the emergency use authorization for the vaccine requires no effective treatment. I'm not to say that anybody would be that cavalier with lives to make their reason not to want to preach about the data that a lot of other countries are using. But if it is that way, that's, you know, pretty perverse. And in all honesty, the other thing is it's, you know, I'm kind of a Hayekian when I think about how knowledge is actually created. It's most closed or socialized economies failed not because there wasn't smart men at the top. It's because the smartest men at the top sometimes, not only sometimes, never have all the knowledge. Okay, and so in all honesty, you know, it's called the distributive knowledge theory. I mean, it's basically people trying things and trying different things. Usually, a good answer rises to the top, and instead we've said, you can try this, you can try that, you can't try this, you can't try that. That's not the way that you know, knowledge is found. And I think that's, you know, again, whether it's a Soviet commissar in 1918 telling you that this is the price of steel and this is how much poundage our country needs. Well, by 1921, they opened up the Soviet economy to actually start have market pricing. Same kind of concept. You know, if I was the NIH director, I'd say, go try everything and I'll pay to keep the data. Because in all honesty, I think it's a disservice that we're only trying certain things. We have lots of medicines. Heck, we have more medicines than we ever have in history. And, you know, other countries are trying things that we're not allowed to, which is kind of crazy. So.
Yeah. Is the state causing the problem in Alabama?
I mean, it's more, I would say it's more the administrative state in general, meaning, you know, the centralized administrative state. And a good example would be the CDC. I mean, the CDC itself should be collecting data and releasing data to the doctors. Well, they haven't released really good data since April. They've just given us their opinions. And in all honesty, that's not what they're there for. They're there to give us the data. They'd like to see it. Let the guys that went to med school look at it. And to me, that's, you know, I'm not saying they're hiding anything. I'm just saying they're not doing their job.
Well, it's the practice of medicine.
Yeah.
That's
So,
the voice to figure out what works.
and the last thing is that the CDC, especially in the last 2 years, has become a political body. And that's, I hate that. Because, you know, a lot of what they did, I mean, the CDC of the 90s, they were very, I mean, a reliable arbiter of truth. And now you can see it. That a lot of what they're giving isn't the data. It's their opinion on the data. And in all honesty, I don't really care about their opinion. So.
Do you know if it's true if the CDC asked hospitals not to report vaccinated patients when they came into COVID?
No, they did not keep up with it unless it reached the hospital. They changed that data in May, so they will keep up with it if it reaches the hospital. But if a test is actually positive in the outpatient setting, it's not actually recorded as a vaccine or what we call vaccination breakthrough until they're hospitalized. And that's fine. Meaning, but again, it does make the data a little bit more. You know, you got to look at it. But again, they're not even releasing the data. So I mean, I can't even comment
They're
on
counting
that.
unvaccinated cases who are not hospitalized, case in point. And I truly think you kept me from the hospital with what you prescribed me. But, so they're counting, they're not giving us.
It's apples to oranges, but even then, we're not even allowed to see the data to actually, because I mean, in all honesty, if you release the data to us, we can we can account for all that stuff, but they're not even doing that. And then in all, in all honesty, it's changing that rule at the state level. I don't think it happens. I mean, I still have to turn in all my positive cases every day. I mean, it's not I think that the state numbers are probably not reflecting that, which is why the CDC's data is so different than some states' data. And it again goes, I mean, it's almost creating like mistrust, and mistrust itself is not good currently. And so they should all be on this. Let's all decide what we're going to say is this, and what's going to say is this. Not have Alabama. We report to the ADPH every day our positive cases, and then they only send us certain positive cases that the CDC wants to count, and that's just I think it's bad math. So.
I